Good morning, good afternoon, and good evening, everyone. Thank you for joining us today for this PATH live forum where we'll be discussing the evolving landscape of malaria chemoprevention with focus on innovation, integration, and real-world impact. We are grateful to GSK for their support in making this session possible. So my name is Caroline Phiri-Chibawe, and I'm the Deputy Senior Technical Advisor for PMI-Rich Malaria at PATH. I'm delighted to be moderating today's conversation. So you're all very, very welcome, and we look forward to a very, very interactive discussion today. We'll start by going over a few quick logistics. Unfortunately, we are experiencing some audio issues with our French translators. Rather than delay this webinar, we would like to ask our French-speaking attendees to kindly use the live captions feature to translate today's discussion. We will be sharing detailed instructions on how to turn on the closed captioning in the chat. Sincere apologies for that, but we would really like to hear from you. So we want to hear from you all during this conversation. So please feel free to share your questions and comments by submitting them in the chat or Q&A box at any point throughout the discussion. I'll be monitoring your input, and I've got some colleagues who are joining me to monitor the inputs, and we'll be saving time at the end for an audience Q&A. And just one final note on logistics. This session is being recorded and will be shared with all the registered participants after the event. So just seeing that participants are joining and from all over the world, we are seeing government representatives, community organizations and NGOs, donors, as well as private sector partners and others. Thank you all for joining us, and we look forward to this 1 hour of discussions. So as an overview, I'll first introduce our panelists and then briefly frame the conversation before diving into a facilitated Q&A with each of our speakers. So we are honored to be joined today by an outstanding group of health leaders. We have Dr. Jane Achan, who's the principal advisor at the Malaria Consortium. We also have Dr. Roly Gosling, the Professor of Global Health, London School of Hygiene and Tropical Medicine. And we also have Dr. Junior Voundi, Head of Malaria Chemoprevention, National Malaria Control Program of Cameroon. Thank you all for being with us today. We truly appreciate your time. Now, I'll just briefly frame our conversation today. So we'll go to the first slide. Thank you. So, chemoprevention. Let's start by grounding ourselves in what we mean by when we talk about malaria chemoprevention. At its simplest, chemoprevention is about stopping malaria before it starts, giving preventive medicines to people who are at risk so that they never get sick in the first place. So in endemic areas, we are looking at ensuring that we have drugs given or medication given, preventive medicines given to people before they get sick, or if they are sick, that those who are infected, so that can be able to clear the parasite. The approach has had its biggest impact in protecting children under 5, even pregnant women and communities living in high burden areas, in the endemic areas. So when it's well implemented, it actually means fewer fevers, fewer hospitalization, and ultimately fewer deaths. It's one of the strongest tools that we have in the malaria prevention toolkit. We'll have the next slide. So seasonal malaria chemoprevention, or SMC, is now well established. It's used in places with very distinct rainy seasons, where children receive monthly doses of preventive treatment during the high transmission months. This approach already protects more than 48 million children every year. What's newer is perennial malaria chemoprevention, or PMC, designed for places where malaria transmission is constant throughout the year. Instead of short bursts of protection, it offers a continuous coverage building on the lessons of SMC. And importantly, malaria chemoprevention doesn't sit alone. It's increasingly being linked with other tools like the malaria vaccine, the monoclonal antibodies. So we are looking at a layered future we're looking at a future of layered complementary protection. For the next slide, what is our question? So the question isn't whether chemoprevention works. The question is, because the science is already clear about that. The real question is, how do we deliver it at scale? So today we have this opportunity to be able to discuss that in more details with our very, very wonderful team of panelists. On the opportunity side, we know the approach saves lives. It strengthens other malaria tools like vaccines and bed nets, and it has potential to reach new settings and populations. But there are challenges. Financing and policy adoption often lag behind the evidence. We also are not surprised that we are seeing delivery systems and the supply chains can also struggle to keep up. Community trust and engagement is also very important. And without that, even the most effective tools won't achieve their impact. So as we go into today's discussion, I would like to pose this question. How do we make sure these proven tools are delivered equitably, sustainably, and at the scale needed to truly change the trajectory of malaria? So as my group of panelists are here, we're going to dive into the discussions, and I'll ask each of the expert speakers to basically speak something about this topic. So as I said, we have 3 speakers. We've got Dr. Jane Achan, Dr. Junior, and Dr. Roly. So I'll start with Jane. Based on your clinical and research experience, what have we learned about the impact of malaria chemoprevention on children and other vulnerable groups? And what challenges remain in making these benefits consistent and long-term?
Thanks, Caroline, and happy to be part of this very important conversation. Specifically to respond to your question, I think that from the research and work that has been done so far, there's really solid evidence that malaria chemoprevention has delivered large benefits and has also had profound impact on the health of this population. And we are talking about children and other vulnerable populations. So in a number of the earlier cluster randomized studies and also in the large-scale routine rollout, some of the interventions, if I could, for example, focus on seasonal malaria chemoprevention, it has consistently reduced clinical episodes of malaria, and the rates that are reported are between 70 to 90% during the period of protection or during the high-risk periods, really. In addition to that, there have also been significant declines in severe disease, so different severe forms of malaria, and an estimated on average about 42% reduction in child mortality in some of the pooled analyses that have been done. In addition to that, I think there are also some very important indirect benefits. So through chemoprevention, we prevent repeated infections of malaria. And what that does, it also reduces moderate to severe anemia and the benefits related with reduction of severe anemia. So for example, better growth, better development, and also better cognition in the relevant population. Also, at the population level, I think we do know that with good coverage and good adherence, chemoprevention has also been shown to reduce local transmission. So in addition to preventing the disease in the population that is targeted, it also contributes to reduced transmission within the population context. And as you've mentioned also, I think the other vulnerable population is pregnant women. The benefits are obvious in that population as well. So what do we see? We see about 29% reduction in low birth weight, 31% reduction in neonatal mortality, but also benefits in terms of reduction of maternal anemia and also reduction of maternal morbidity across that spectrum of care. So clearly, we do see that IPTP, for example, has really demonstrated significant impact in the response to maternal and infant health at that scale. However, like you've mentioned, even in light of all that success, I think there are significant benefits that remain, and challenges that remain, and we need to address those challenges if we are to see the sustained benefits over time. one of the common challenges that we see is coverage and adherence challenges. So there are significant coverage gaps that remain. And I think in the context of current reductions in funding, those coverage gaps have become more apparent, but also suboptimal adherence. Data shows that for the program to have impact, adherence for each round should be greater than 80% for us to benefit in terms of the efficacy. And also, they should be overall, that adherence for each round. So not just the first round, but throughout the cycle of administration. And anything lower than that minimizes the community level benefit that we see. As we track adherence, I think that self-report has also been shown to exaggerate or overestimate adherence. And within the context of the programs, I think we need to have better approaches to reporting adherence and support adherence in that context. One of the bigger problems, for example, that are currently being addressed is drug resistance. So repeated administration of really the same drug. So if you look at the backbone of all these chemoprevention approaches, it's sulfadoxine pyrimethamine alone in PMC, or sulfadoxine pyrimethamine plus amodiaquine in the context of SMC. So we have programs that have actually shown an increase in the prevalence of molecular markers of resistance in the context of repeated administration of these different drugs. So really, the context of drug resistance is one of those important aspects. But also, I think access and equity issues, we do see that in contexts where there are remote populations, difficult to reach populations, or even in the current changes of climate, extreme weather events have also, for example, impacted on access for some of the population. So ensuring equity is addressed in our programmatic context is quite important. Side effects are not such a major challenge because most of the drugs are well tolerated, but it's also important that we keep monitoring the side effects. And I think overall, the sustainability of these programs and equitable access remain really key challenges. So we do know that chemoprevention works, but it's important that we maintain the long-term values like you've mentioned. And how do we do that? So we really need to ensure that we sustain high uniform coverage across board. We need to have, for example, objective methods of verifying adherence across board. And we also need to ensure that we are embedding surveillance for resistance to guide regimen choices. And I think that if we do not have these safeguards as part of the programs, I think some of these impressive gains that we've seen with chemoprevention will be very difficult to sustain. So thank you. Back to you, Caroline.
Thank you so much, Jane. And I like, I think, the direction that you were able to tell us the benefits and also what the challenges have been, especially looking at the implementation at country level and what we are actually going through now with the shrinkage of funding, especially where countries have to prioritize whether this is the intervention that they want to proceed with. But it's a very, very important intervention. So I would like to go to Junior, who's going to give us a country perspective. From your experience leading malaria chemoprevention efforts in Cameroon and hearing what Jane has said, what do you see as the biggest obstacles to implementing these programs effectively at scale, whether related to financing, supply chain, or community engagement?
Okay, thank you, Caroline, for the questions, and hello to everyone. Let's say the obstacles that we can face actually could be during the whole process of implementing PMC in a particular setting. Firstly, what we need to have is firstly the political will. When a country is willing to adopt the PMC policy and now going to where we are going to implement this intervention, because what countries usually don't do specifically is this subnational tailoring before implementing the activity to make sure to know in these different settings, this is where we can implement these at this time, and also overviewing which type or which system or which health system where they are going to integrate this intervention. It is a routine intervention, and it needs to just follow what is already existing to make sure that the caregivers will really will maintain this commitment, this engagement to really make sure that the infants have these PMC interventions. So after this, obviously there is this the conception or the design of the tools, because to make sure to capture the data and then to do these evaluations at the end, is really important that the tools should be feasible, to make sure that the healthcare providers will not feel as if this is an additional work they are doing, because they have many tools actually. And if you add again one tool, or rather you can just try to fit some few indicators on PMC in the existing ones, because many countries don't use the same system. Like in Cameroon, we use the EPI system to deliver PMC, but other countries use the child health program, or also they have these outgoing intervention to make sure to capture the children. So after this, we also really the greater problem is the continuous supply of SP, because if there is an interruption in the supply chain, this will not really help, because to calculate really the effect of PMC, we need to make sure that the children took every doses, or as actually we can actually have the protective effect of one dose, but since SP is not immunizing, it is not like you gain immunity as you take the different doses, but within a certain time, within a certain period of time, when you take PMC, normally you can have a good protection. And the other obstacle that we could face right here is the training of actors, because actually you have to train every actors at each level. They have to master how to implement the dosage of the SP for the child age, and because actually we have, let's say, many countries implemented PMC using SP 500 by 25. Rather, we have these new manufacturer who are pre-qualified by the WHO, or who provide the SP, the pediatric SP, the 250, and this is easier to use than the 500 that you need to break down the tablets and dilute in water, give to the child, and it is not really helpful for the healthcare providers to manipulate, because at the time you are not sure that you will break down the tablet at the exact dosage to make sure that the children will take it. So these are some challenges, and also what we can face now. It is the community engagement, because if you don't make sure that the beneficiary, the direct beneficiary, are there to the intervention, it won't work. And to make sure that this work, we usually go through this co-design process, like by inviting the beneficiary and developing all these tools together, to make sure that when they arrive at the health facility, they are compliant, they feel like they participated to it, and they accept easily this intervention. So at this stage, PMC is quite cheap. So when it is already introduced in the routine system, it doesn't necessitate any other efforts rather than the knowledge from the healthcare providers and the community engagement. So I think, Caroline, I will stop from there, but if there is any other questions, we can continue. Thank you.
Thank you, Junior. And I like the way you've actually talked about subnational tailoring, especially when prioritizing, ensuring that not one size fits all, but basically targeting the interventions, and also including how we work with the community. Going to Roly, from a global research and implementation standpoint, what do you see as the most critical gaps in our current chemoprevention tool, whether in data, delivery, or alignment with other interventions?
Yeah, well, thank you. And thank you very much for hosting this webinar at such a great time. I think we can't really move forward without really acknowledging the current crisis in the global financing environment. And where does chemoprevention fit in the current country priorities, but also in the funding priorities? And we've seen global advice from the Global Fund and WHO prioritization that is somewhat confusing regarding chemoprevention. So it does seem that SMC remains within that prioritization, and we've thankfully seen donors pulling together to ensure the funding for this season, and we have to hope that that is continued forward. For me in particular, working in the PLUS project, which is a PMC implementation project, it's very worrying for us because PMC doesn't sit that highly in the prioritization currently. Yet we know that there's a huge unmet burden. So the great success of the SMC campaigns protect. I think in 2023, they protected about 19 million children under the age of 2. Yet in the perennial areas, we see about 37 million children in moderate and high transmission areas that are unprotected. So if you like, there's a bit of an equity issue there that we're doing really well in some areas, and then there's a lot of children that are left unprotected in others. So I think it's important for us to kind of look at this as a big challenge moving forward. It is great to have followed both Jane and Junior, who have covered enormous areas of interest and have given a lot of fantastic background. So I'm just going to kind of fill in some gaps that I see. So the first thing is to kind of look at the mechanisms but which chemoprevention work. So it's not rocket science. It's not trying to induce an antibody response or some immune response to protect you against malaria. It is quite straightforward that if you get the medicine and you take the medicine, and as Jane already mentioned, we really are on pretty basic medicines. We're on sulfadoxine pyrimethamine, which is a one-off dose, and in SMC areas you're getting 3 additional days of amidiaquine, and we do worry about the 3 days, whether children get that or not in real life situations. And then if we're kind of looking at the SP side of things, the sulfadoxine pyrimethamine, it is an old drug and there is established resistance to it. And certainly in areas of Central Africa, so where we're working with Junior in Cameroon, but we also know in Nigeria, there are some new mutations coming up in the DHPS gene that it will impact we think will impact the efficacy of SP. So we in our PLUS project, we've actually been measuring that. So we should be able to either reassure you or otherwise in the coming months on whether these new mutations do in fact impact on SP. we do have evidence that SPAQ remains effective in the presence of those in the presence of those mutations, and SPAQ certainly does seem that it would be protective for at least 30 days and maybe up to 42 days. So that's a good thing for us all. We do know that SP resistance is different across Africa, and that is dependent on genotype. And in East Africa, we do have a genotype that is, we know causes problems, and some modelling that we've published earlier, late last year, does show that we'd expect the efficacy of SP to be reduced from what we think is a fairly decent 30-day protection to around a 12 to 16-day protection in East Africa with the mutations that are very frequent there. We do think that in high transmission areas, even with reduced protection with these mutations, that PMC or just SP will be an effective tool, a cost-effective tool at reducing cases of malaria and subsequent severe disease and subsequent mortality. So we think that PMC in high transmission areas, even when there is substantial resistance, we think that PMC will still be cost-effective. But the PLUS project is currently analysing data, and by the end of the year, you will have all our data, and we'll be able to be give you concrete evidence for that. The kind of second area that Jane and Junior have mentioned that is worth kind of pushing on a bit more is the coverage aspect. So Jane mentioned the community coverage needing to get, for the community effect, to get coverage up to 80%. But remember, there is the individual effect. And if a child gets the intervention, they are protected. And of course, you want more children to get that to see a community effect, but you will still see a reduction in malaria, cases of malaria, severe malaria, and deaths just by less than full coverage. So coverage does lead to kind of the community effect and perhaps great cost effectiveness, but still a child getting that pill, it will do them good. So what else then did I want to say? I wanted to say about access. Access is a challenge. So, we'd be interested in looking at different ways of access. How PMC is currently implemented and currently thought is through having attachment with certain individual vaccinations or contacts with the health system. But I think what we've found across the PMC research projects, there are many, is that if you say you're going to have 5 contacts or 6 contacts, you may get 2 or 3 contacts that are successful. So I think we have to move with these away from kind of fixed schedules and become much more flexible, much more opportunistic, and to be really pushing for when children get seen in any way. So Junior did mention, in Cameroon, we're looking at EPI, but in other places with cross-section, with outreach like measles catch-up campaigns, or with vitamin A, or with deworming campaigns, chemoprevention could be attached to all of those and increase and improve coverage. Okay, I've probably spoken too much, but with research, just to kind of mention, there's such a range of research that could be done. There is, the delivery, the tool itself, giving a drug. SP, the new SP formulation requires water. Not everywhere has water, not everywhere has cups, not everywhere has spoons. Can you make that more simple? What else? I don't know. There's so much more, but we'll come to those, I think, with the questions.
No,
I'll stop.
Yeah, thank you so much, Roly. There's so much that you can talk about, and I really like the way you talk about the practicality at the end of it all in being able to deliver. You might have tools that are available, but are you able to deliver them? And those are the practicalities that are there in the field that you've raised. So I would like us to look ahead to the future. What can we learn as we look ahead to the future? So I go back to Jane, and I know, Roly, you talked about PMC. So PMC is gaining attention as a complement to SMC. What do you see as the most important factors that will determine whether PMC becomes a routine part of prevention in high burden countries? And I know that Roly touched on some of those. Jane, over to you.
Yeah. Thanks, Caroline. And I think this coming through after Junior and Roly's contributions, I think it's quite key. And like you rightly mentioned, I think PMC does have significant potential to complement SMC, but there are critical issues that I think need reflection that would really impact on whether it becomes a routine practice in some of these high burden settings. And I think one of the key gaps is the evidence base for PMC. And this is not just clinical trial evidence, but also implementation feasibility evidence. Even following the WHO recommendations in some of the countries, the malaria control programs really wanted context-specific evidence to inform the deployment and rollout of PMC. So really, the evidence as to how the impact of PMC will be on sustained reductions in parasitemia, severe malaria, anemia, beyond what we see in clinical trials is quite key. And also the fact that the cost effectiveness measures really against the current standard of care, which will be more critical in the current times with the different funding cuts. And I think Roly has ably alluded to this. I think the other aspect that which is also critical that should be considered, drug safety, tolerability, and really the pharmacodynamics of the different regimens in the context of this relatively younger population, really of infants and toddlers, especially because this is repeated year-round dosing. How does that impact on different aspects of the infant? And of course, related to the drugs is also the question of resistance. And I won't really dwell so much into that because Roly has alluded to the resistance, but really year-round pressure. These children are getting the product year-round, and how that selects for haplotypes or molecular markers of resistance. This is an aspect that would need to be inbuilt within any deployment strategy for PMC in the different contexts. And then I think one of the other elements is really programmatic feasibility. We do know that in the context of SMC, this is really concentrated within a few months in the year. And there is a platform that has been set up for the delivery of these 3 to 4 cycles per year. So PMC requires continuous delivery. Indeed, there are some platforms, the EPI platform, child health days, integration within the community worker health force or operations of work. It's quite critical to reflect on that kind of continuous delivery, embedding the training, like has been mentioned, but aspects of supply chain throughout the year, availability of these drugs, the geospatial spread and the micro planning to ensure that whoever needs this product, however remotely they are located, actually does have access to this to prevent any coverage gaps in that age group. And I think also this is something that Junior ably mentioned, community uptake and adherence. How are we communicating the impact and the role of this intervention in the context of everything else that's happening to this child? How accurate are we getting our caregiver trust to ensure that there's optimal uptake? And then we sustain that beyond some of the first doses that are directly observed. So really to ensure the monthly coverage is sustained, we need a significant amount of caregiver trust, and the communication around that is quite key. And I think also, just to repeat how relevant and important that is, the policy and the financial commitments. I think without the two, it's difficult to determine how much they scale up. Indeed, there's been significant endorsement by WHO. I think the recommendation has been there since 2010 with a more flexible update that was subsequently done in 2022. But the integration into national programs is another context that we need to consider. And really, together with predictable donor and domestic financing, those will be key for sustainability. So really, in short, the transition of PMC from these multiple pilot projects that we've had, I think, across the different countries to what routine practice should be would really be determined by the clinical efficacy, the pharmacological safety of the profile of the products we are using, resistance monitoring, the capacity of these delivery systems that we'll be using, but also, most importantly, the political and the financial commitment of the different programs and the settings where we were. Yeah, thank you.
Thank you. And I think you also, I just wanted also to mention, you're also building this on a platform that is the EPI platform, where even the routine immunization that we already, the traditional immunization program, you don't have optimum coverage. So I think I like what you mentioned about ensuring that the EPI, the child health program, the supply chain adherence by the providers as well as the community should be optimum for this integration to happen. Thank you so much, Jane. Roly, I'd like to go to you and just to look at PMC again as the new tools emerge from PMC to monoclonal antibodies. How do you think countries and partners should think about integrating these within their broader strategies and delivery platforms?
Yeah, well, I think that's a kind of major question, isn't it? We thoroughly believe in a combined approach that you need more than one intervention. And is it that the layering on of the interventions actually are synergistic and build upon each other, or is it that through one delivery channel, a child is protected, let's say through a bednet distribution, but they don't come for vaccine or they don't come for their chemoprevention? And I think understanding the reality of protection on the ground will help us much more understand, especially in the high burden, high impact countries, why interventions are performing to a level lower than expected. I think that I mean, certainly things like the monoclonal antibodies would be a game changer if they're deliverable. So I think that's really the problem with monoclonals. But let's kind of focus a little bit on the impact of the vaccine. The vaccine is being rolled out. It seems from kind of local knowledge that, it is very rapidly impactful on cases, and we see cases going down in those children that get it. But we have this kind of problem of the weakness of the delivery system, which you've already mentioned, in the first year of life, let alone the second year of life. In the second year of life, EPI is really struggling. However, we could be thinking of this in the kind of resource-starved environment that we think of, that we're living in, that the EPI system not only provides benefit to malaria by delivering vaccine and PMC, for example, and bed nets occasionally, but also through its reduction of respiratory disease through pneumococcal vaccine or diarrhea through various other vaccines and things. So it could be that in this period of restricted financing, that instead of kind of trying to build all these different complex layers for different delivery to cover all the children, we do invest in the health systems, and we invest in strengthening systems rather than building new delivery systems on top. So when I'm thinking of kind of new tools, I think that we should be thinking of new tools, not only how they impact the disease that we're aiming to control, but how they strengthen the health system and support the core of the health system. And that would also come in just into, how aid is delivered. And I think that we've all been pretty shocked by the collapse of donor assistance for health, from the US and European countries. But maybe this is a great time to kind of readjust ourselves and say, we don't want parallel delivery systems. We want health system strengthening.
Yes, that's what I would love to hear. Health system strengthening, building the countries to be able to build their systems, that any new intervention that comes in is integrated, and as you said, a parallel program. Thank you so much for that. And I think it's a good segue to Junior from Cameroon, who's in the health system, just to tell us more. What have we learned about the global and national policy frameworks which are supporting SMC implementation? And what adjustments are needed to ensure long-term sustainability, especially looking at our health systems?
Okay, let's say, firstly, SMC is being implemented in a campaign mode where it mobilizes a lot of resources, humans as financial resources. And within this short period of time where we have this high transmission of malaria. And what we learned so far is that actually the system is quite weak because we still depend on external funding. And what Jane said, that is really important to have this political commitment where the country itself needs to hold on their responsibilities to make sure that they will continue to support or to finance this intervention independently of any other external support, which are still welcome, but really the countries need to have this ownership of this intervention. We have the means, but it will be a real issue of political commitment. And let's say from that, but as Roly said, also PMC could be these escape, like, because it is cheap. It could be cost effective than SMC. Seeing all the resources which are being deployed to implement SMC, I think PMC is this opportunity that could make us quick from these challenges. But actually, we have no evidence of implementing PMC in high malaria transmission regions, actually. So the country is not yet sorry. So the country is not yet willing to go through that path. But what we are exploring now for the sustainability is more of like changing this campaign mode to an hybrid mode, because the door-to-door necessitates more money. But if we can make sure to implement fixed points in health facilities, but this will need a greater campaign of sensitization to make sure that the parents will bring their child to the fixed point to benefits from the SB ACURE. But still will remain the issue of the doses of the 2 and the 3. Those amodiaquine doses that we don't always observe if the child took or not. And it will still need maybe some supervision to make sure that these children effectively take SB ACURE or these the 2 and the 3 doses. So with this hybrid mode, we have the fixed points, and we have also the community health workers who are already integrated in our health system, because they carry out this community-driven intervention, which are routine. So they do this door-to-door sensitization, these home visits, focus group discussions. So they have all these panel of activities that they carry out in the community, and we can easily use them to deliver this medication during the period where the child are more susceptible to have malaria. So the strategy that actually we are figuring out is like the fixed point will only be for the localities that are not greater than 5 kilometers around the health facilities, and then those localities that are greater than 5 kilometers, they will benefit from these community health workers. And also the other additional thing with the community health workers is that they already implement case management in the community. So each time they reach a household, and maybe if the when they check the eligibility of the child, if the child has malaria symptoms, they can test the child, and if it is positive, they can treat directly the child in the household. So these are the ways that we are exploring this sustainability, and also actually we are working on an early warning system. This early warning system will help us to detect or to predict the time where the transmission could start in every specific district. So we can even go to the health area. So now the SMC will not be as usual, like launching at the same date, but now every district with this information now could launch his administration of SMC according to the prediction on when the child of the district have to begin this SPA. So these are some ways. These are some, let's say, what we are our reflections on how to make sure that even if we don't have this funding that will continue, but at least we can maintain the effective administration of SPA cure according to the transmission period in the different settings. Thank you.
Thank you, Junior. Thank you so much. And you've really touched, I think the sustainability definitely should be coming into place, especially if you look at integrating in already existing, you have the community health workers already on the ground, you already have the program already on the ground. And thank you for actually elaborating that from a country perspective. So we have some questions from the audience, and I think now it's time for questions and answers from the audience. So I have two questions. The first one is addressed to Jane. So Jane, can you share your thoughts on coverage impacting adherence, resistance rates, and efficacy of programmatic implementation?
Thanks, Caroline. I think those are very important elements that we really need to think through as we roll out programs. And I will start with really the coverage and adherence dynamics. And just for clarity, when we talk about programmatic coverage, we are talking about the reach across the population. And when we talk about adherence, really at the individual level, that really means dosage completion. And they are two distinct aspects, but quite interrelated. So how do they interplay in the context of programmatic implementation? So we do know that with a high coverage and the machinery that really goes into driving high coverage, there's a lot of contact or more frequent contact between the community and the community health workers or the team that is deploying SMC. And what does that do? That it helps to really ensure that positive behavior is reinforced, which would mean that, adherence to the product is better, and that really improves overall adherence rates across the community. However, there's also the contrary picture of what could happen, especially if coverage is expanded too rapidly without the due diligence in supporting the supervision, the communication that goes around with that kind of programmatic implementation. So with very rapid expansion in coverage without commensurate support to the uptake of the program, then we get problems. You may reach the children with the first round, for example, but then the proportion of children missing dosing with subsequent rounds becomes a challenge. And what does that do? It overall impacts on the adherence rates, but also the quality of the programmatic implementation overall is a problem. And I think that's one of the things that we've seen with really large scale coverage. That should be coupled with interventions, one, to ensure that there are more objective assessments of adherence to the drugs, but also interventions to support adherence at the individual patient level. So really how I would look at coverage and adherence in the context of a program. I think the other element is also coverage and drug resistance and the selection pressure that comes along in that aspect. Of course, with high coverage, the program level drug pressure basically increases. And with increased drug pressure, you'd expect really selection of the different alleles and haplotypes that could drive resistance. But usually the critical imbalance is when there is increased coverage without much adherence. So without the support for adherence, why is that particularly dangerous? Then you're having suboptimal adherence with lower drug levels achieved. So essentially you're exposing this parasite over a prolonged period of time to suboptimal drug levels. So that critical overlap becomes a particular challenge. So with increased coverage, there needs to be objective measures to support adherence. Poor adherence in that context of high drug pressures leads to suboptimal drug levels that expose this parasite, further increasing the risk of, development of drug resistance. And really in those contexts, there should also be mitigation strategies to ensure that there is surveillance, but there is also support for adherence, and those systems are in place to detect the early hotspots where this may be coming up. I think the final element that you mentioned is coverage and programmatic efficacy. Like I mentioned earlier on, I think for optimal epidemiological efficacy, we do need coverages of about above 80% with low inter-community, inter-cluster, or inter-village or district, whatever our means of deployment, with low variability at that level. Rory did mention that at the individual patient level, it's important that one child is covered. But there is a challenge when you have epidemiological gaps. So if you have certain pools of people that are not actually taking up the drugs, for example, the peri-urban informal settlements, conflict zones, difficult to reach areas, those remain parasite reservoirs that continue to maintain transmission, and despite high national coverage levels, the disease burden remains because of these epidemiological gaps that we see in coverage overall. So in the context where we want to scale up rapidly, the machinery around ensuring good drug supplies, good micro-planning, if there are households missed, mechanisms in place to ensure that those missed households are recognized and then redosed are quite important. In fact, for some of the modeling studies, it's been shown that this kind of heterogeneous coverage reduces programmatic efficacy by up to 30%. So it is quite an important aspect that needs to be considered. So really, having said that, I think if we look at coverage, programmatic efficacy, and resistance, what I could say is that we need high uniform coverage to maximize protective efficacy, but also with means to verify adherence and also measures to track resistance. I think most programs are really combining those different aspects. And when these are done together, it really ensures that the benefits of chemoprevention are maintained long term. So it's really how we approach the programs. And I think it's quite an important question because all of them are interrelated and all of them impact on really the benefit and the impact of these chemoprevention approaches in this vulnerable population. Thank you.
Thank you, Jane, and thank you. Really, really tackled that question. You've really covered all the important areas. I've got one more question before I ask all of you to give us your comments, last words. Maybe I can ask Junior, what role do you civil society organizations play in malaria chemoprevention? And how can we ensure that they're adequately resourced? And then I know you should be working with some CSOs in Cameroon.
Yeah, yes, actually we have these civil society organization that help us firstly during the in fact they help us with advocacy. They help us to make sure that they bring together every stakeholders, every interesting parts for the implementation of these activities. They help us also, since they are closely related to the communities, they help us also with these sensitization activities, these community engagement activities, and the working also with the health services. They also help us to bring like to catch up children, like if they have these children that are not that haven't been to the vaccination self-service, they can help bring the children to the health facility to benefit from these, and they also help us in the supervision of the community health workers during their work. So, but mainly we usually call them for the advocacy part, because the let's say the actually we elaborated our multi-sectoral strategic plan by committing every ministry that could have a role play in the implementation of malaria intervention, including PMC. And this was very helpful because PMC covers children under 2, actually in Cameroon. And the ministry that are in charge of this group age did this commitment, like they gave some fundings to support this intervention, and also even at the parliamentary, they also help us to ensure that the Ministry of Health will put more funding for malaria than before, and this was effective. The Minister of Health enlarged the budget, and it was really a great time for the NMCP since then. So this is how we work closely with these CSOs, and we really appreciate the collaboration with them. They are always invited around the table when we have discussions, rather for grant making or grant proposal, or even to write our national strategy plan. So they are always invited around the table to make sure that we also gain from them.
Thank you. I think we've spoken a lot and we've heard from the panelists. And I just want to give you each less than a minute to just say last few words. And I'm asking if our audience could just bear with us maybe an additional 5 minutes beyond the hour, because we're coming to the hour. So I'll start with Roly. Less than a minute.
Okay.
What message would you have for the audience?
I'm ready for this. So I think, to acknowledge that chemoprevention is one of the tools in the toolbox. I think we need to, for research purposes, we need to know how things work in combination. We need to ensure that those people that don't have access, and that's a health system delivery challenge that we have to acknowledge and work on. And long term, we have to get sustainable funding, and we have to be less dependent on donors. So my messages are, better listening to the affected communities that don't have coverage, to have flexible programming to adjust our delivery strategies to get to those people that currently are not delivered or get poor service. And I think we have to acknowledge that health systems deliver poor service, and we have to improve that quality, and then depend less on outside funding, on donors.
Thank you. Jane?
I mean, I think Roly has taken all the points, but just to add on, I think just briefly, I think we do acknowledge that chemoprevention saves lives. And as a global health community, I think our task is to ensure that there is sustainable and equitable access for everyone that needs this intervention. So just a quick conclusion on that, yeah.
And uniform coverage, I have not forgotten that. And Junior?
Just to say also that PMC is quite cheap to be implemented. So every country that is willing to implement PMC, we have our platform, the Community of Practice for PMC. They can reach out, and then we could help them also to develop any strategy or anything that they could wish, so that we could help them to implement PMC in the country. Thank you.
Thank you, Junior. So just to say thank you to Junior, Roly, and Jane for the opportunity to speak with you today and for sharing your thoughts on chemoprevention, SMC, and PMC. I also want to thank GSK for supporting this, and as well as PATH for supporting this webinar. I hope you've all had an opportunity to hear more and understand more. So thank you all, and I wish you a good rest of the day. Thanks. Bye.
Thanks.